Good night, everyone. I'm Dr. Stefan Ramrup, and today I'll be presenting on venous anatomy of the brain. So typically, we're more so aware of, especially at a more junior stage, the arterial territories, but venous anatomy is just as important and can honestly sometimes be less forgiving and more variable. So it should be considered just as important as arterial. So with that in mind, why does venous anatomy matter in neurosurgery? So unlike arterial injury, which tends to produce immediate neurological deficits and stroke patterns that are often predictable, venous injuries are different in the sense that they frequently produce delayed deterioration, progressive edema, and frequent hemorrhagic conversion, as well as refractory raised intracranial pressure. So the venous drainage of the brain operates under a low pressure, high variable valvular system. And because there are no valves, pressure changes transmit freely across the different territories, which means that if you have an obstruction or a sacrifice of a single vein, that can propagate congestion beyond the immediate surgical field. So again, unlike arterial infarcts, venous infarcts can be often hemorrhagic, associated with marked vasogenic edema, poorly confined to arterial territories, and sometimes clinically delayed. So the learning objectives of this presentation will be to one, describe the organization of your superficial, deep, and dural venous systems in a three-tiered system, as well as identify surgically critical venous structures afterwards from that. Then correlate venous anatomy with operative approaches and principles that you can apply to preoperative planning and intraoperative decision making. So to break down the cerebral venous anatomy, it is helpful to think of it in terms of a three-tier hierarchical system. The first one would be superficial cortical venous system, which will drain your cerebral cortex and your adjacent subcortical white matter. The second tier will be a deep venous system, which drains more centrally located structures, so your thalami, your basal ganglia. And then the third tier will consist of your dural venous sinuses, which function as your final outflow channels. And that'll include like your superior sagittal sinus, your straight sinus, and transverse sinuses, and consist of more rigid structures. They're more rigid structures. So the overall flow hierarchy is from cortex and deep structures to your collecting veins to your dural sinuses, and finally to your internal jugular veins. So venous anatomy can be more variable than arterial. So to understand why, it's important to look at some early embryological development patterns. So in early development, the brain is surrounded by a primitive mesenchymal layer called your primitive meninx, and venous drainage at this stage occurs through a longitudinal channel known as your primary head sinus, which runs laterally and posteriorly here. So as your cerebral hemispheres will expand, your venous drainage will reorganize, and your primitive plexus will begin to consolidate into larger longitudinal channels. So your superior sagittal sinus will develop within the falx cerebri as your hemispheres separate. And inferiorly, you'll have your straight sinus, which forms a connection between the deep venous system and your posterior drainage pathways. Simultaneously, your posterior drainage system evolves into what becomes known as the transverse and sigmoid sinuses. And what's important to note is not all primitive channels will regress symmetrically. So that can result in one transverse sinus, for example, becoming dominant, your torcular herophily, or your confluence of sinuses, being asymmetric in terms of drainage, or a persistent falcine sinus, which may remain if normal straight sinus development is incomplete. And some individuals can retain accessory venous channels. So looking at the superficial cortical venous system, it's responsible for draining the cerebral cortex and adjacent subcortical white matter, as I said before. These veins, they tend to be thin-walled and operate under low pressure. And importantly, the entire cerebral venous system is valveless, as I had said before. This means that the flow direction is determined by pressure gradients and collateral pathways which can develop. And then congestion can occur throughout this whole system. So your superficial cortical veins will drain into your dural venous sinuses and then through your bridging veins itself. So these bridging veins traverse the subdural space before emptying into the superior sagittal sinus, transverse sinus, and cavernous sinus. These systems can be encountered frequently during interhemispheric approaches, parasagittal meningioma resections, temporal craniotomies, and sylvian fissure dissections. An issue with them, again, unpredictability is the issue. So a small appearing cortical vein can represent the dominant drainage portion for an entire cortical territory. And there is no reliable intraoperative method to determine the functional importance of a given vein, which will, again, produce some catastrophic consequences such as venous congestion and progressive edema. So within this superficial cortical venous system, you have several large anastomotic veins, sorry, which serve as key drainage conduits between venous territories. So starting off, you have the vein of Trollard, or it's also known as your superior anastomotic vein, that typically connects the superficial middle cerebral vein within the sylvian fissure to the superior sagittal sinus. And it courses superiorly along the parietal region. And in some hemispheres, it represents a dominant drainage channel from the sylvian region to the sagittal sinus. You then have your vena vallae, or your inferior anastomotic vein, which will connect your superficial middle cerebral vein to your transverse sinus. And that will run posteriorly along the temporal lobe and often represents the primary venous outflow of the temporal cortex. Um, from a surgical perspective, the vena vallae is particularly critical. Injury during a temporal craniotomy or subtemporal approaches through a temporal root can result in temporal lobe venous infarction. The superficial middle cerebral vein itself runs along the sylvian fissure, draining the frontal and temporal opercula, and its termination can be variable. So it may drain into the cavernous sinus or the sphenoparietal sinus or connect posteriorly into the transverse sinus via the vena vallae. These anastomotic veins are highly variable in dominance. So in some hemispheres, the trollard is dominant, and in others, your labial is dominant. And occasionally, a superficial middle cerebral vein drains directly without any strong anastomotic dominance. The variability explains why preoperative venous imaging is important when operating near your sylvian fissure or your temporal lobe. So if you have to sacrifice, or if there's sacrifice of a dominant vein of Labe, that can produce temporal lobe edema, aphasia, if in the dominant hemisphere, hemorrhagic venous infarction, or seizures. Similarly, if you have injury to a vein of Trollard, a dominant vein of Trollard, that can result in parasagittal venous infarction. So bridging veins are among the most surgically consequential components as well as the other ones I just mentioned. They connect the cortical surface veins to the superior sagittal sinus by traversing a subdural space. So as they pass from the cortical surface through the arachnoid and dura to enter the sinus, they are relatively unsupported at this point. So that can make them vulnerable to shearing forces, which is why in trauma or acceleration, deceleration injury, that can result in tearing of them, which can result in acute subdural hematomas. The bleeding will occur between your dura and arachnoid mater, directly reflecting the course of these veins. They typically are encountered during interhemispheric approaches, parasagittal meningioma resections, and Falx-based lesion surgery. Unlike arterial occlusion, again, which can produce predictable territorial infarction, if you coagulate a small bridging vein to improve corridor access, for example, that can result in, again, your progressive venous congestion, capillary hypertension, and blood-brain barrier breakdown and vasogenic edema. So there are different patterns of superficial venous drainage and hemispheric dominance. So we had touched on this before. If you have a Trollard dominant pattern, the superior anastomotic vein provides primary connection between the sylvian region and the superior sagittal sinus. Parasagittal manipulation will have a greater risk in this situation. In Labe dominance, the inferior anastomotic vein represents primary outflow of your temporal lobe into your transverse sinus, and injury here can result in temporal venous infarction. And then you have superficial middle cerebral vein itself being dominant in some cases, draining anteriorly into the cavernous sinus or parietal sinus without strong anastomotic connections. So again, just to stress, there's high variability when it comes to these this section of the cerebral venous system. So it's important to look at preoperative MR venography or CT venography or venous phases of angiography if available, particularly in dominant hemisphere surgery or temporal lobe approaches or parasagittal resections. So now we're just going to look at an overview of the deep cerebral venous system. So the deep system drains the centrally located structures of the brain. So these are functionally dense and they're bilaterally organized. So this will include your thalami, your basal ganglia, your internal capsule, deep white matter, ventricular walls, and your chorion plexus. And unlike your superficial system, which can demonstrate significant variability, the deep system tends to be more anatomically consistent and far less tolerant of injury if it happens. So at the core of the deep venous system consists your paired internal cerebral veins, which form from the union of your thalamostriate and septal veins. Yeah. Posteriorly, they converge to form the vein of Galen, also known as a great cerebral vein. And in parallel, your basal vein of Rosenthal drains the median temporal lobe and the midbrain structures, and that also joins the galenic system. As I said, it drains bilateral midline structures. So injury or thrombosis can result in bilateral thalamic infarction, coma, hydrocephalus, and pretty bad neurological outcomes as a result of the injury to these areas. So injury to these structures, you need to be aware of that typically when there is pineal region surgery or third ventricular surgery, or even with endoscopic third ventriculostomies, as well as colloid cyst resections and deep AVM surgeries too. So looking more closely at the structures in the deep venous system, your internal cerebral veins, they are pair structures that form near the foramen of Monroe by the confluence of two major tributaries, your thalamostriate and your septal vein. The thalamostriate vein drains the thalamus and caudate nucleus along the floor of the lateral ventricle, and your septal vein will drain the septum pellucidum and the medial ventricular wall, which unite to form your internal cerebral vein. So from there, the paired internal cerebral veins will run posteriorly within the roof of the third ventricle, and they lie between the two fornices, just inferior to the splenium of the corpus callosum. So an important spatial relationship to remember for them would be that the fornices are lateral, and the internal cerebral veins lie just medial and inferior to them, and the third ventricle is below. With this, this anatomy is very important. Again, as I said, in endoscopic third ventriculostomies, colloid cyst resections, and pineal region surgery in particular. An injury to one internal cerebral vein may cause unilateral deep venous congestion, but bilateral injury or galenic compromise can result in, catastrophic bilateral thalamic infarctions. So the thalamostriate and septal veins, as you said, which form your internal cerebral vein, the thalamostriate will run within your thalamocaudate groove, the junction between the thalamus medially and the caudate nucleus laterally. And that will course along the floor of your lateral ventricle, collecting venous blood from the thalamus and basal ganglia. Septal vein runs more medially along the septum pellucidum and the medial ventricular wall, and it drains structures adjacent to the medial ventricle. From a surgical perspective, this is very important for intraventricular surgery, as I said, with the internal cerebral vein before. Now looking at the basal vein of Rosenthal, it forms anteriorly near the anterior perforated substance, receiving tributaries from the deep middle cerebral vein, anterior cerebral vein, and your striate veins. And from there, it will course posteriorly within the ambient cistern. Its anatomical relationships are important. It runs lateral to the midbrain, medial to the uncus and medial temporal lobe, near the posterior cerebral artery, and very close proximity to cranial nerve 3. Posteriorly, the basal vein will curve medially beneath the splenium of the corpus callosum, and it will join the internal cerebral veins or directly contribute to the formation of the vein of Galen. This vein will be encountered in petroclival approaches, mesial temporal lobe approaches, suprastellar infratentorial approaches, and pineal region surgery. An injury to the basal vein can produce venous congestion of the midbrain and medial temporal lobe. Unlike superficial venous compromise that we talked about before, deep venous congestion here can lead to altered consciousness, memory deficits, cranial nerve dysfunction, and brainstem edema. This here is just an image showing the basal vein of Rosenthal, because I believe in the first image here, these first couple of images, it's not present, where it showed an overview of the deep cerebral venous system, which shows your internal cerebral veins forming a vein of Galen complex with your thalamostriate, which you can see more accurately here, joining your internal cerebral vein to form your vein of Galen. So more on the vein of Galen, or more accurately termed the great cerebral vein. This represents the final convergence of the deep cerebral venous system, and it's formed from the union of the paired internal cerebral veins, typically posterior to the third ventricle, beneath the splenium of the corpus callosum. In addition, it receives the basal veins of Rosenthal, so it can integrate drainage from the medial temporal lobes and midbrain. And it lies within the quadrigeminal cistern, positioned posterior to the third ventricle, superior to the tactile plate, and inferior to the splenium, and just anterior to the straight sinus. From the vein of Galen, the blood will drain directly into your straight sinus, and the straight sinus we'll talk about further. when we get to the sinuses. So the galenic straight sinus complex represents the final convergence, again, as of the deep venous system. And all deep venous drainage from the thalami, basal ganglia, internal capsule, and ventricular structures will pass through this region. And it's encountered most commonly in pineal region surgery, supracerebellar infratentorial surgery, and occipital transtentorial approaches. So in these corridors, the vein of Galen and the straight sinus will define the superior boundaries of safe dissection here because of how catastrophic injury can be. Now we're just going to touch on the overview of the dural venous sinuses. So now that we've reviewed the superficial and deep venous sinuses, we now transition to the dural venous sinuses. So unlike cortical or deep veins, the dural sinuses aren't traditional veins. So they are rigid endothelial line channels formed between layers of dura mater. Because they're encased within dura, they do not collapse under normal intracranial pressure, and they also lack muscular walls and valves. So functionally, they will serve as the final common drainage pathway for the brain. And both your superficial cortical veins and your deep galenic system ultimately empty into these sinuses before entering your IJV, your internal jugular veins. So the sinuses are intimately associated with dural affections, particularly the falx cerebri and the tentorium cerebelli. So the falx contains the superior and inferior sagittal sinuses. The tentorium cerebelli will contain your straight and transverse sinuses. From a surgical standpoint, sinus anatomy will influence your craniotomy placements, as well as your tumor resection approaches, posterior fossa approaches, and skull-base surgery as well too. And any injury to any major dural sinus can result in massive hemorrhage, or if occluded, venous hypertension and infarction. So starting off with the superior sagittal sinus, it is the primary midline dural venous channel draining the superficial cortical venous system. And it runs within the attached superior margin of the falx cerebri, extending from your crista galli anteriorly to the confluence of sinuses posteriorly. In cross-section, the sinus is triangular. This is sagittal, with its base against the skull and its apex directed inferiorly into the falx. It receives numerous bridging veins along its course, particularly from the frontal and parietal lobes, and it also contains arachnoid granulations, which will facilitate CSF absorption into the venous system. So from surgical standpoint, again, how does it relate? So the superior sagittal sinus will define the medial boundary of many cranial approaches. In parasagittal meningiomas, the sinus can be compressed, invaded, or even partially occluded. So sometimes decisions must be made regarding sinus preservation or reconstruction or resection. In interhemispheric approaches, the sinus and its bridging veins will limit medial retraction. Anterior portions of the superior sagittal sinus can be occasionally ligated safely due to collateral drainage that it might have. However, in the posterior third, particularly near the confluence of sinuses, is much less tolerant to this sort of sacrifice. An injury to the sinus can result in rapid, potentially life-threatening hemorrhages due to its non-collapsible nature and high flow. Looking at the inferior sagittal sinus and the straight sinus. So the inferior sagittal sinus runs within the free margin of the falx cerebri. And unlike the superior one, which lies along the attached superior border, the inferior sagittal sinus is smaller and it drains the medial hemispheric surfaces. Posteriorly, it will join the vein of Galen to form a straight sinus, and this junction occurs at the intersection of the falx cerebri and the tentorium cerebelli, which is a key anatomical landmark to be aware of. The straight sinus then courses posteriorly within the tentorial attachment and will drain into the confluence of sinuses. And this region represents the structural convergence of your superficial and deep venous sinuses. This falx tentorium junction that's formed is very important and encountered in pineal tumor surgery, occipital transtentorial approaches, tentorial meningiomas, and as well as deep AVM surgeries. Because the straight sinus carries the entire output of the galenic system, compromise here can produce bilateral deep venous congestion. And unlike the superior sagittal sinus, which can have some segmental tolerance, like we said before, the straight sinus is generally not expendable. And injury can result in catastrophic deep venous infarction, like any injury to the deep venous system. Another important nuance is that anatomical variation exists at the confluence. So some patients demonstrate asymmetric drainage patterns, which can influence surgical contexts such as posterior fossa surgical planning. So your transverse and sigmoid sinuses now, they represent your primary outflow from the cranial vault to systemic circulation. The transverse sinus extends laterally from your confluence of sinuses along the tentorial attachment, and it will curve inferiorly as the sigmoid sinus, forming an S-shaped course that will then exit the skull through your jugular foramen as the internal jugular vein. This system can also be asymmetric. So in most individuals, the right transverse sinus is dominant. However, left dominance and codominance are also common. And in some cases, one transverse sinus may be hypoplastic or nearly absent. This asymmetry is embryologically determined and can have major surgical implications. For example, in posterior fossa surgery, particularly in retrosigmoid craniotomies, as the size and dominance of your transverse and sigmoid sinuses will determine how much exposure you can safely achieve. And any drilling near a dominant sigmoid sinus can carry a risk of severe venous outflow compromise. And if you have any compromise of a dominant transverse sinus, that can result in venous hypertension, which can result in more specifically cerebellar edema, as well as raised ICP and venous infarctions and cranial nerve dysfunctions. So preoperative imaging should include evaluation of sinus dominance, as this should never be assumed, as you should never assume symmetry. So looking at the cavernous sinus, it is a paired venous plexus located lateral to the sella turcica, containing really important neurovascular structures that we'll get into. So it will extend from the superior orbital fissure anteriorly to the petrous apex posteriorly, and it's highly interconnected and receives blood from the superior and inferior ophthalmic veins, your superficial middle cerebral vein, and your sphenoparietal sinus. And it will drain posteriorly via the superior and inferior petrosal sinuses into your transverse sigmoid system and your jugular vein. These extensive connections that it has explains the spread of infection from the face to the cavernous sinus. From a surgical standpoint, or the surgical relevance, the cavernous sinus is typically encountered in transsphenoidal pituitary surgery, skull-based tumor resection, cavernous sinus meningiomas, and carotid cavernous fistula management. So unlike the other dural sinus we discussed, it's not a simple linear channel. It is a venous plexus and a trabeculated venous space located just lateral to the sella turcica. So here you can see the contents of the cavernous sinus. From lateral to medial, you have your cranial lobes 3, 4, 5, 3, 4, as well as divisions of cranial lobe 5, 1, and 2, as well as the carotid artery medially and your abducent nerve medially. So in terms of other additional dural venous sinuses, you have several smaller ones that are important as well too and can be encountered frequently. So you have your superior petrosal sinus, which connects your cavernous sinus to the transverse sinus and runs along your superior border of your petrous temporal bone. That could be encountered in cerebellopontine angle surgeries and tentorial incisions. You have your inferior petrosal sinus, which connects the cavernous sinus to the jugular bulb or your jugular vein. And that's clinically significant, particularly in endocrine practice, as it can be assessed during inferior petrosal sinus sampling to differentiate pituitary from ectopic ACTH secretion. The occipital sinus runs in the midline within the falx cerebelli, and though often it is small, it can be enlarged in cases of transverse sinus hypoplasia, and that can be encountered. It could be encountered in posterior fossa midline approaches. Then you have the intercavernous sinus, which connects your right and left cavernous sinuses anterior and posterior to the pituitary gland, and these channels explain venous bleeding encountered during transsphenoidal surgery, if that's being done. And finally, you have your sphenoparietal sinus, located along the sphenoid ridge, which may receive the superficial middle cerebral vein and influences venous drainage patterns in pterigonal approaches if that's the case. This illustration, just basically shows the outline of some of the sinuses just mentioned, just by the intercavernous sinuses. So looking at some of the issues that can occur within the venous anatomy system. So you can have cerebral venous sinus thrombosis, which can represent an obstruction of venous outflow within the dural sinus system. If a sinus becomes thrombosed, venous blood cannot exit the intracranial compartment efficiently, and your arterial inflow will continue, which will result in a backup of blood, resulting in venous congestion and increased capillary pressure, which can eventually lead to venous infarction. So typically the most commonly involved sinus would be a superior sagittal sinus followed by your transverse and sigmoid sinuses. Thrombosis of your straight sinus or your deep venous system is less common, but it will be more severe because it compromises drainage of your thalami and deep structures. You can have several predisposing conditions that can increase the risk of cerebral venous sinus thrombosis. So this would be hypocoagulable states such as inherited thrombophilia, pregnancy, and the postpartum period associated with it, or contraceptive use, malignancy, dehydration, or infections of your paranasal sinuses or your mastoid. Clinically, the most common presenting symptoms in patients would be headaches, which are often progressive, associated with features of raised ICP. Patients may also present with seizures, focal neurological deficits, or papilledema. And in cases involving a deep venous system, patients may develop altered consciousness due to bilateral thalamic involvement. Diagnosis is primarily radiological. So on CT imaging, thrombosis of the superior sagittal sinus may produce a classic dense triangle sign. CT venography or MR venography demonstrates absence of normal venous flow within the affected sinus. And MRI as well may also demonstrate venous infarction, which can often appear hemorrhagic and will not conform to the arterial territories. In these cases, management, if present, typically involves anticoagulation, even in the presence of hemorrhagic venous infarction, as the underlying pathology is thrombosis rather than a primary hemorrhage. This illustration here will just demonstrate the relationship between the superficial cortical veins and the dural venous sinuses and how they have an obstruction of venous flow, how it will affect the brain parenchyma. So in your blue, you have structures that represent your normal cerebral venous drainage. And then in the red, you have the red segment represents within the superior sagittal sinus thrombosis, which will obstruct your venous door and as a result in blood not draining effectively, leading to possible infarction. So more on infarction itself. So venous infarction occurs when you have venous outflow from the brain being obstructed, leading to congestion, cerebral edema, and oftentimes hemorrhagic conversion. So the process typically begins with venous outflow obstruction. So that can be as a result of mentioned before, cerebral venous sinus thrombosis, or cortical vein sacrifice during surgery, or external compression by tumors or thrombosis of the deep venous system. And again, unlike arterial occlusion, arterial inflow to the affected brain region will continue. However, you have impaired venous drainage, causing blood to accumulate because the arterial flow isn't affected, but your venous drainage is affected, resulting in the increased venous and capillary pressures, which will result in a venous congestion. So venous infarcts typically do not conform to arterial territories, and instead they often involve both cortex and subcortical white matter, and they can cross arterial boundaries. You tend to get prominent vasogenic edema and patchy hemorrhages, and your mass effect may be disproportionate to the size of the infarct present. Clinically, patients present with symptoms similar to cerebral venous sinus thrombosis, so headaches due to raised intracranial pressure, as well as seizures being common, and neurological deterioration. So there's also dural arteriovenous fistulas. These are abnormal vascular shunts occurring within the dura mater, connecting meningeal arteries directly to the venous system itself. So unlike AVMs or arteriovenous malformations, these lesions lack a true nidus, and instead, multiple dural arterial feeders converge on a venous sinus or cortical vein. Dural AV fistulas are generally acquired lesions rather than congenital malformations, and they're commonly associated with dual venous sinus thrombosis, trauma, surgery, or other conditions that produce venous hypertension. And these factors end up stimulating angiogenesis within the dura and lead to the development of abnormal arteriovenous connections. Clinically, these patients can present with pulsatile tinnitus, headaches, seizure, focal neurological deficits, or intracranial hemorrhage. The arterial supply typically arises from the meningeal branches of your external carotid artery, although you can have contributions from your internal carotid or your vertebral circulation that can also occur. The clinical behavior of your dural AV fistula is determined primarily by its venous drainage pattern. So the Borden classification stratifies lesions based on this pattern. So type 1 fistulas drain only into dural venous sinuses and generally follow a benign course. Type 2 fistulas demonstrate drainage into a dural sinus with retrograde reflux into cortical veins. Your type 3 fistulas drain directly into cortical veins without an intervening sinus. And the presence of cortical venous reflux is the key determinant of it and its aggressive behavior. So when arterialized blood flows retrograde into the cortical veins, these veins become dilated and fragile, which significantly increases the risk of intracranial hemorrhage and venous infarction. And treatment for these patients typically aims to eliminate the abnormal shunt and relieve venous hypertension. And this is most commonly achieved through endovascular embolization, although microsurgical disconnection or radiosurgery may be used in select cases. This image on the right-hand side just demonstrates the radiological features of a dural arteriovenous fistula, which again is the abnormal direct connection between meningeal arteries and the dural venous sinuses. So this was taken from Radiopedia, and what you're seeing is numerous tortuous aberrant veins at the root entry zones here, more pronounced on the right-hand side. And on the right, you can see impinging on the facial and vestibular cochlear nerves. On the left is just a image uh, basically outlining your Borden classification. So there are also vein of Galen malformations, which are rare congenital vascular lesions involving the deep venous system of the brain. So despite its name, the lesions do not arise from the true vein of Galen itself, but instead they result from persistence of an embryological structure known as a median prosencephalic vein of Markowski. So during normal developments, this embryonic vein regresses as the paired internal cerebral veins form and unite to create the true vein of Galen itself. But in your vein of Galen malformation, this regression fails. So you have multiple arterial feeders from deep cerebral arteries forming direct arteriovenous shunts into the persistent median prosencephalic vein during early fetal development. Typically, this happens between 6 and 11 weeks of gestation. And the result will be a massively dilated midline venous collection located in the region of the vein of Galen. They're typically characterized by extremely high flow arteriovenous shunting because the arterial blood is diverted directly into the venous system itself without a capillary bed in between. So the venous circulation becomes exposed to high arterial pressures. So the clinical presentation of this can vary significantly with age, and it's typically a reflection of the hemodynamic consequences of high flow arteriovenous shunting. So in neonates, the most common presentation is high output cardiac failure. Because a large portion of cardiac output is diverted through the cerebral arteriovenous shunt, the heart must pump significantly increased volumes of blood to deal with it. And that can result in early tachycardia, cardiomegaly, and congestive heart failure shortly after birth. And you can sometimes get a cranial bruit on examination. In infants, the dominant manifestations are typically related to venous hypertension as well as impaired cerebrospinal fluid dynamics. So often these kids will develop hydrocephalus and progressive macrocephaly due to impaired CSF absorption and venous congestion. And developmental delays may also occur due to chronic cerebral hypoperfusion and venous hypertension. Older children, on the other hand, may present with seizures, headaches, or focal neurological deficits. Radiologically, these lesions can often be detected prenatally or in early life using ultrasound, which will demonstrate a midline cystic vascular structure with high velocity Doppler flow. MRI, as well as MR angiography, can provide excellent anatomical detail, and it can typically show a dilated midline venous pouch located posterior to your third ventricle, along with the enlarged vening arteries. However, digital subtraction angiography, or DSA, still remains the gold standard as it allows for detailed characterization of your arterial feeders, your venous drainage, and your shunt architecture. Typically, main form of treatment for vein of Galen malformations is endovascular embolization, which is usually performed in staged procedures. A gradual reduction of shunt flow is important to avoid any sort of abrupt hemodynamic changes. Neonates with severe cardiac failure often require stabilization in intensive care before getting any definitive treatments. And microsurgical resection, on the other hand, is rarely performed because of the deep location that it typically has in the complex vascular anatomy of these lesions. So now we're going to look at some surgical principles when dealing with the cerebral venous anatomy. So when it comes to this, you have particular high-risk regions. So the core surgical principles are: one, preserve dominant venous drainage pathways. The deep venous system must be noted to not be expendable. You want to identify venous anatomy early in your surgical corridor, avoid any traction or unnecessary coagulation, as well as treat the major veins as boundaries for safe dissection. So the high-risk surgical regions that we want to look at would be sylvian fissure, your parasagittal region, your temporal lobe approaches, as well as your pineal region. So often, a big question is whether a vein can be sacrificed or not. So in general, smaller superficial cortical veins may occasionally be sacrificed if adequate collateral drainage exists. Similarly, if you have some non-dominant tributaries of the superficial midget cerebral vein, coagulation of them can be tolerated. As said before, the anterior portion of your superior sagittal sinus has also been ligated in select cases due to greater collateral venous drainage. However, several venous structures should always be preserved. So that would include your vena vallae, which is often the dominant venous outflow of your temporal lobe, the superficial middle cerebral vein when dominant, and your bridging veins entering the posterior superior sagittal sinus. And as you said, the deep venous system before. So preoperative assessment of the cerebral venous system is an essential component of your planning. So the goal would be to identify your dominant venous drainage pathways, evaluate the patency and dominance of dural sinuses, and map the location of major cortical and bridging veins. So MR venography provides a non-invasive overview of the venous sinuses, while CT venography, on the other hand, offers high spatial resolution of your sinus anatomy. You also have DSA, as said before, which will remain your most detailed method for evaluating dynamic venous drainage pathways, particularly in vascular lesions. This is all very important in terms of planning, preoperative planning for surgical resections in specific cases, such as parasagittal meningioma, as I said before, or temporal and skull base approaches. So to conclude, cerebral venous anatomy is highly variable and consists of three main interconnected systems: your superficial cortical veins, your deep venous system, and your dural venous sinuses, which form an integrated network which is responsible for your overall cerebral venous drainage. From a surgical point of view, the deep venous system is particularly critical because it lacks any sort of significant redundancy, which makes it very high risk in terms of operating around and devastatingly injury if damaged. So dominant venous pathways must be identified and preserved when possible. Other important concepts is that venous injury often produces delayed neurological deterioration, frequently due to hemorrhagic venous infarction. And for this reason, veins shouldn't be viewed as obstacles, but rather as structures that will define your safe corridors. And finally, understanding of venous anatomy is essential for recognizing and managing venous pathologies, such as cerebral venous sinus thrombosis, infarctions, dural AVFs, and vena gallid malformations. So with that, thank you, and these are my references.